Okay. Okay. So moving on to case 2, that is a young female, 19-year female patient with missed miscarriage and evaluation of the product of conception. Remember that the product of conception, this kind of specimen is quite regularly given in an exam. You need to see that whether it is a normal product of conception, that is a retained product, or there is some evidence of molar gestation. So they are interested in it because as we can see, the villi are some kind of showing circumferential trophoblastic proliferation. There is a circumferential trophoblastic proliferation. There is extravillous trophoblastic island. So all these are pointing towards a molar gestation. If you go higher, so you don't see any vascular channels within the villi. So all these are pointing towards a molar gestation. Okay, and one important thing is that there is no kind of normal villi per se, because the gestational age is low and you can see some areas of cystic changes. These are areas of cystic changes. So you favor a complete mole, particularly in this case, and you work up with P57 because P57 will be dead negative in this particularly case. And you say that if you are considering at least partial mole, so there what will be the staining pattern, and ultimately you need to refer this case for gestational trophoblastic disease center in UK, and there the further follow-up will be done. So this is how you complete this workup and say this is a gestational trophoblastic disease, and you favor a complete mole, particularly for this case. Moving on to case 3, 41-year male patient, that is he is a returning soldier from Afghanistan, and with a 6-month history in the lesion that is enlarging and affecting both hands. So particularly in this case, we have multiple bits of squamous, skin over here, and they are densely inflamed. Okay, so they are densely inflamed. There is no such epithelial abnormality. We can see the corneum layer, and there is mild, you can say, spongiosis going on, but there is nothing worrisome about it. The underlying dermis, superficial dermis, and the deep dermis in having a dense population of inflammatory cell, mainly chronic in nature. You can see mostly these are plasmacytoid cells, there are histiocytes, lymphocytes, and if you go on higher magnification, even though in this section you can see there is some intracellular organism. Okay, there are a few dot-like organisms mainly located intracellularly. That area were showing. I think the scanning is bit not good, but even though you can see some nuclear very small perinuclear dots, which are quite suggestive of a leishmania in this particular case. So you should suggest that I am suspecting some infective etiology. Sorry. So there are some infective etiology. I favor Leishmania particularly in this case. My close differential will be histoplasma. Look, there are a few dot-like organisms. So my differential will be histoplasma, but the histoplasma will be negative for Giemsa, which is positive in Leishmania, and the silver stain will be positive in histoplasma, whereas silver stain will be negative uh, in case of Leishmania. And you can suggest some microbiological correlation, number one. Number two, that antigenic ELISA test is confirmatory, and the gold standard confirmatory test is DNA PCR for this case. And say that this can have a typical 3 phase. This can have a cutaneous phase. This can have a visceral phase, or it can have a postdermal. Yeah, postdermal collager Leishmaniasis, that is PKDL. So there are many form of so many form of Leishmania you can mention, and you mention that it is infection is transmitted by sandfly. So these are common vector which is mainly located in the tropical regions. So this is how you put up some extra brownie points, and you get some extra point above 2.5, that is a passing mark. Okay, so that is the thing. And the follow-up needs to be done after, with antimony test, antimony treatment. So this is the standard treatment for Leishmania. Moving on to case 4, it is a female 50-year patient with lesion in the right breast. So this is a kind of perimenopausal age group, some kindly on the older age group side. So we can see from the scanner view that it is mainly a stromal rich lesion, and we can see the ink over here, and the adipose tissue, that is the margin of the lesion is quite irregular, and it is infiltrating kind of very irregularly distributed, and it is infiltrating into the adjacent fat because of the irregular border. And at one point it is the ink margin is positive with the lesional cells. Now moving on to the lesion, so it is a fibroepithelial lesion, so stroma rich, and you can see there is some temporal heterogeneity, because some more cellular area that are more pink, and some edematous area that are more hypercellular. And if you go to the hypercellular area, that is uh, more cellular looking, you can see some mitosis. Actually, when I was uh, just going through the cases, I was able to detect mitosis. But yes, it is not that more than 5 per 2 millimeter square, or you can say it is not more than 5 per 10 hyperfield. I don't see any heterologous element, but there is irregular margin. There is a stromal hyperplasia, that is stromal overgrowth. You can mention that I don't see any epithelial element in any low power, in several low power actually. So these are the features of borderline phyllodes. As I don't see any obvious mitosis or obvious any heterologous differentiation of malignant type, I don't consider it to be malignant with this section. But in the workup, you should mention that I will do further sectioning to look out for more cellular areas, more mitotically active areas, to rule out any possibility of malignant phyllodes. So that should be your approach for this case. And there is another thing is that the epithelial element is bit hyperplastic. Uh, to me, it is bit monotonous. If you go by the comment that is given in the Leeds website, that you can suggest a possibility of epithelial hyperplasia even up to a degree of low grade DCIS or ADH, particularly for this case, that is acceptable, because you know that the fibroepithelial lesion usually have a epithelial hyperplasia also, but it is not up to a range of any intermediate, or so up to a not a range of not a range of high grade DCIS or kind of that. So you can suggest that I see some hyperplasia, I will evaluate in further sectioning. So that's how you can approach the epithelial component. But you should always think of the borderline phylloids, that is that at the margin positivity, that is R1 margin, and you should discuss this case in the breast MDT, so that they can do a kind of revision surgery particularly for this case. Okay, So this is how you approach this case, and you say that there is a follow-up protocol, that is atypia, mitosis, the cellular stromal overgrowth, and malignant mesenchymal lesion for that is known as Singapore nomogram, particularly for phyllodes of borderline and malignant category, and that helpful for follow-up for this case. So Singapore nomogram, if you say, that will give some brownie points, particularly for this case. So this is how you approach this case 4. Moving on to case 5, this is a 64-year male patient with 7 mm diameter, a pearly white nodule in the anterior aspect of left shoulder. So remember, it is a elderly age group male patient, and what you see, this is a kind of wedge sectioning, and the margin is clear. The epithelium is bit stretched out there, but there is clear demarcation between the overlying epithelium and the tumor. The tumor is disposed in diffuse sheet, and they show quite a degree of nuclear pleomorphism. There is conspicuous mitosis and nuclear pleomorphism, and there is prominent nucleoli. So this is a poorly differentiated neoplasm. You can suggest a DD of melanoma, particularly for this case, because you don't see any uh, squamous or any adeno component in it. Even though you are not getting pigment per se, you obviously should a differential of amyloidotic melanoma, particularly cutaneous metastatic to this site. So you need to kind of do a workup. You keep a broad differential that you should favor a melanoma, a poorly differentiated carcinoma, like that. And sometimes you may think of some poorly differentiated histiocytic hematolymphoid neoplasm also, but you should keep a broad differential with melanoma favoring in it, because and you should once it is done, that the usual broad marker, that is cytokeratin, CK, that is pan CK, the LCH, S100, and SAL4. These are the broad general lineage marker you should do. And after confirming S100, you can keep a further prognostic marker like BRAF and NRAS, particularly for any targetable therapy, and a melanoma workup, whether the patient has any cutaneous or any visceral malignancy, because sometimes it can have a nasal or the gastrointestinal melanoma. So that thing should be discussed, and a proper evaluation, a multidisciplinary discussion, and that the prognosis is poor because it is cutaneous metastasis, so it have a poor prognosis. So that kind of workup and that kind of prognostic information will give a separate mark, and you will get some extra brownie points in this particularly case. Okay, so moving on to next case, that is a case 6. It is 52-year female patient with a colonoscopy done, that show a single polyp of 5 mm diameter in the distal sigmoid. So this is what you see, that it is a polypoidal tissue. There is no abnormality, particularly to the epithelial element, but this is a stroma-rich polyp. So remember, the stroma-rich polyp have handful in number. So either they will be kind of spindle cell lesion or inflammatory fibroid polyp, this kind of thing. But in this particular case, if you go down and if you go to the higher magnification, you see this kind of large cells with their irregularly clustered. So this kind of ganglion cells with prominent nucleoli, they are the characteristic of ganglion cells. and the stroma is rich with spindle cells with eosinophils, and there are scattered collections of lymphocytes with formation of lymphoid aggregate. So, ganglioneuroma is common to the colon, and it is a bit rare type of polypoidal lesion, but yes, it has been given at least twice in a FRCPath exam. But the thing is that you should keep a this ganglioneuroma as a diagnosis. You should not provide any differential, particularly this case, and you can do some other confirmatory markers and neuronal markers and neuron specific enlarge and all that to confirm it, even though it is not necessary because the morphology is quite characteristic. So you say that it is completely excised and it should not, it is a benign thing, and it doesn't have any chance of recurrence, and the bleeding could have been because of the polyp, and once the polyp has been removed, the clinical symptoms should alleviate. So this kind of prognostic information will be marked accordingly. Okay, moving on to our next case, case 7. It is another interesting case. That is a 49-year female patient with previous breast surgery. This is a quite a important clue. And now the patient have presented with axillary lymphadenopathy. So once we go to the higher magnification, we can see that lymphoid element has been replaced with what we mostly see, this kind of foamy cell, they replacing the lymphoid follicles which are quite compressed, and the foam cells, and that the foam macrophages are those have multivacuolated cytoplasmic element, this kind of thing are there. So these are actually silicon lymphadenopathy. So the history that the patient is having a breast surgery is important, and the thing is that if you go to the higher part, you see that, just a minute. If you go to the another bits, you should not mention, you should not miss that there are other focal area of metastatic carcinoma, and it is quite low grade in nature. So this is a metastatic breast carcinoma along with a silicon lymphadenopathy. So this is how it is a dual pathology, and the silicon part you can confirm it with the previous surgery and the silicon implant that has been done, and that is a polarized microscopy that will have a kind of birefringence to the silicon to element. Okay, so this is how you work up this case, and you can say that it is a metastatic lesion. So you need to do a ERPR and HER2 for prognostic. That is a predictive marker, particularly to say that what is the status at present, so that they can give certain hormonal therapy, particularly for this case. Okay, so this is a dual pathology case, and you expect almost every year they try to give one case that had some dual pathology in it. So in this year, it was this. Okay, so the case 8 is a male 33-year. It have a nodular lesion on the dorsum of tongue. So if you see that the lining epithelium is thrown into papillary fold, and the underlying musculature, the resident intrinsic muscles are all okay, but under the epithelial lining, you see this kind of eosinophilic homogeneous material which have some this kind of very characteristic histological artifact that is known as cracking artifact. It is a case of amyloid tongue. So, so particularly for this case, you have a lot to write because once amyloid is there, this is a scoring case, and you should grab the opportunity to scale up your marks so that you can make a few of the losses that have already incurred or yet to occur. So in this case, yeah, so in this case, you must and say that I will do a congorate with thick section under room temperature, and I will examine the congorate under polarized microscopy. It should give a apple green birefringence, and not to forget about electron microscopy, that is it will have a randomly distributed fibrils of 7.5 to 12 nanometer, and it is randomly distributed. These are the two golden points you should not miss. And apart from that, you should refer this amyloid case to the National Amyloid Center. So these are the three blanket statement you must remember. And see that amyloid is almost they repeat in every, I think, every alternate session. So either in spring or autumn, in every year they have a amyloid case, and this is the particular case. This is coding, and you should do whatever what you should write whatever thing, and you must say that I don't see any kind of dysplasia in the overlying epithelium, because the primary thing was the nodular lesion and it was excised. So the primary clinical concern where this is a malignancy. So you must include that I don't see any kind of dysplasia or any in situ changes or intraepithelial carcinoma, particularly for this case. So this is how you complete this case and grab some opportunity to take. Yeah, and also you need to mention about the various types of amyloidosis, primary and secondary, and how will you work up. Like you can do immunohistochemistry that is available, and you can do some plasma cell related markers or all that, because sometimes it can be associated with plasma cell dyscrasia. So all these are part of evaluation. So the workup and the remark section should be quite sizable. You takes the opportunity of that particular case. Okay, so moving on to case 9. This is a male 59-year patient with lower urinary tract symptoms, and there is a abnormal bladder mucosa that was biopsied and cystoscopy. So this is a kind of biopsy. You should mention that yes, I see a detrusor muscle in it. Meeting has 10 minutes more. I will try to cover as much as possible. So I see detrusor muscle, and in these I see this kind of lining epithelium with hobnailing, and it shows some degree of nuclear changes with nucleomegaly and some nuclear atypia. And if you come down, there is some lay down of basement membrane down down the lining epithelium, and here is a better. So these are the more tubular and more kind of luminal clustering of that epithelium, and they have kind of you can say some degree of atypia. But the thing is that they are kind of have hobnailing and thick basement membrane like areas. So this is quite characteristic for nephrogenic adenoma. So how will you prove? You will do a Paxate, you will do a Amaker to just exclude a possibility of any uh, prosthetic thing in it, and you say that I expect that it will be Paxate positive, and this is a kind of reactive in nature, because these are mostly seen under some chronic irritation. So it can be under some bladder diverticula or some stone or some chronic irritation that is going on catheterized patients. So this kind of thing, there is no kind of urothelial dysplasia or in situ malignancy, particularly in this case. So this is how you complete this section and pass the section. Moving on to case 10, the patient is female 49 and she is ex-smoker, and we have a subpleural lesion that have almost 15 centimeter in greatest dimension. So in this particular case, we have a kind of pleural based lesion which is more of kind of heterogeneous in cellularity. There are areas with more cellular areas like here, and in the cellular area, if you go down, if you can appreciate there are some kind of slit-like vascular channels that we all know, that is known as hemangiopericytomatous like areas, and in the hypocellular area, you see this kind of thick band of collagenous deposition, that is ropey collagen in it. So there are various variation in the cellularity. There is kind of this kind of HPC or hemangiopericytoma like areas in it, and there are some cracking artifact just parallel to the cellular dispositions. So all these along with the and obviously I don't see any cellular atypia, increased mitosis that is more than 4/10 hyperfilled. So these are the point against a malignant thing counterpart of it. So this is a SFT, that is a solitary fibrous tumor, and you say that I will do a CD34 particularly for this case, even though I don't consider synovial sarcoma because I don't see any mitosis or uh, any any hypercellularity, any overlapping epithelial, any biphasic pattern. But I will do a CD34. I expect this to be a strong positive. I will do a stat6 rearrangement to confirm rearrangement particularly for this case. And you say that I will examine the other part of the section to rule out any possibility of malignant SFT. And once it is done, it is ruling out any possibility of SFT. It actually indicates that there is a very minimal chance of uh, any recurrence. So malignant SFT have a higher chance of recurrence, and it can have a distant spread also. So this is how you do the workup. I uh, I I think you should straight away give a diagnosis of SFT particularly for this case, because it is a known thing and a known pleural based malignancy uh, that has known for its occurrence. I will straight away go to case number 16 because there was a request for particularly for this case. Okay, so case 16 is a male 75-year patient who have a gastric polyp, and there was the patient was under investigation for anemia. So I can see this is a polyp obviously, and the beautiful thing is that the overlying epithelium is thrown into multiple villiform areas, villiform architecture, and there is quite a edematous lamina propria. So we can see vascular prominence, vascular engorged. The lamina is inflamed heavily. We can see some there is definite evidence of regeneration because loss of mucin and some nuclear pseudostratification happening, because they are known to occur in any regenerative changes. And the normal gastric foveolar mucosa that is there over here, but even though there are areas of intestinal metaplasia. So this is a quite characteristic for hyperplastic polyp, and it is known to occur in any kind of gastric or gastrointestinal tract, you should rule out the possibility of Helicobacter pylori associated infection if there is going on, and you should say that I will look for deeper section to conclusively rule out any areas of dysplasia, because I know that dysplasia can happen in hyperplastic polyp. So the main thing is that to rule out any possibility of dysplasia happening, particularly for this case. And the thing is that once it is excised, it should not have any chance of recurrence. But the thing is that with the undergoing intestinal metaplasia and all that, you should obviously rule out any predisposing condition, mainly the H. pylori. Okay, so this kind of edematous mucosa, this kind of regenerative changes are quite characteristic for hyperplastic polyp. Okay, I think I don't have any time to discuss any more case because my time is up. I have 2 minutes more. Okay. Yeah. Any question particularly regarding any case that we have discussed so far? Yeah.
Sir, how is gangliocytic uh, paraganglioma different from ganglioneuroma?
Gangliocytic paraganglioma. Paraganglioma will have this kind of Swannian stroma along with irregularly clustered ganglion cells. So that is very characteristic for ganglioneuroma. Uh, gangliocytic paraganglioma is typically located near the ampulla. They are typically known to occur at that location. And they doesn't have this kind of Swannian rich stroma. Uh, I need to go back. I am not very, I have not seen very much of cases. So anybody who want to add some points, how to differentiate? Because this pattern is quite characteristic of ganglioneuroma. So periampullary location, what I remember is quite characteristic. They don't happen in other part of the GI tract. So ampullary by mass, they can have this kind of gangliocytic paraganglioma. Okay, any other questions? So we will have